Hello, and welcome to our Reimagining Long-Term Care webinar series. I'm Neil Dreimer, Director of the Health Innovation Programs at Healthcare Excellence Canada. My pronouns are he and him, and I'm so pleased to be your host today. HEC honors the traditional territories upon which our staff and partners live, work, and play. We recognize that the standard of living that we enjoy today is the result of the stewardship and sacrifices of the original inhabitants of these territories. We must commit to not repeat past mistakes and to work towards more equitable and respectful relationships with First Nations, Inuit, and Métis. Acknowledging the territories and the original stewards of these lands is a fundamental responsibility of our organization and part of our commitment to work towards truth and reconciliation. So I want to make sure I acknowledge that I'm joining you from my home office in Ottawa, which is on the traditional, unceded, and unsurrendered territory of the Algonquin people. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. I too invite you to share who you are and where you're joining from in the chat box. I also wanted to let you know we are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in either of our official languages. If you have a comment or a question, please add it in the chat box at the bottom of your screen. We will look to address as many of your questions as we can during the Q&A session, which will happen during the latter portion of today's webinar. As well, if you need support at any time throughout this webinar, please feel free to reach out to our tech support using the chat feature. I did want to mention that this session is being recorded and will be available on our website in the next couple of days to review and share with colleagues who may have missed it. So it's now my pleasure to welcome our speaker for today, Christina Southey. Christina is a faculty member with HEC and is also a coach on our Reimagining Long-Term Care program. We are so pleased to have Christina join us to present important information on age-friendly health systems and the 4Ms framework. Just a little bit more about Christina. She's an independent consultant and improvement advisor who's worked with clients throughout Canada, the United States, and internationally. She's supported numerous projects in the primary and community care realm, including initiatives focused on COPD, depression, deprescribing, and dementia care. She has also acted as a practice facilitator within various initiatives over the last decade across Canada. Christina has advanced training and proven methods from the Intermountain ATP program in Salt Lake City, and she has applied her expertise in multiple small and large group education sessions and as an in-demand facilitator and teacher in her field. She is an improvement advisor for the Institute for Healthcare Improvement and also teaches on their behalf internationally. She holds a master's degree in community health and epidemiology and lives with her family in Toronto. So please feel free to welcome Christina. And also just a reminder to just drop in your questions in the chat box throughout the presentation. Over to you, Christina.
Thanks, Neil. And thank you for that lovely introduction. I'd like to also acknowledge that, yes, I live and work out of my home office in Toronto. And Toronto is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nation, Inuit, and Métis peoples. And I would like to sort of pick up on something that Neil mentioned at the end of my intro there, and that is that I am, yes, an improvement advisor faculty for the HEC LTC Plus and representing Hub 8, who I've had great pleasure to meet with a couple of times now. I also get the great pleasure to be an improvement advisor with the Institute for Healthcare Improvement. And as part of my work with them, over the last 3, and this being the 4th year, I've had the privilege of supporting the age-friendly health systems work that happens out of IHI in partnership with the John A. Hartford Foundation, and particularly supporting their action communities, which is one of the ways in which we support systems across a number of settings in the US and internationally in being able to test and implement age-friendly health systems and the 4 M's within their context. And so I come to you today to share a little bit about the age-friendly health systems movement, a little bit about the 4 M's and what it's all about, in the hopes that for those of you that feel that this is an initiative, a movement, a framework that would be helpful for you, that you have the ability to explore what that might mean for you, because it's been a movement and a framework that has been incredibly popular for those that we've been able to reach with it in the last, I think we're going on about 5 years now that the movement's been active. So if you go to the next slide. The aim of the age-friendly health systems movement is to, by June 30th of 2023, to recognize over 2,600 hospitals, practices, and nursing homes, convenient care clinics as age-friendly health systems. So one of the things I want to point out about that aim is that the idea behind the movement is that the 4 M's are applicable across a number of settings of care, as you see noted in that aim. And then as part of that work, to do so equitably by race, ethnicity, as well as social orientation and gender identity across the older adult patient population. And I'll talk a little bit in the presentation about how we've looked to understand the lens of equity and how it can be woven through the various steps of the journey to becoming an age-friendly health system. So if you go to the next slide. I won't belabor the point about why this work is something that has been important to the John A. Hartford Foundation as well as to IHI, because I think a lot of you already know this. But briefly, just to say that the reason that this is a movement that has sort of been a focus is because of the 3 dynamics that you see on the screen: the demography of the population and the increasing older adults in our communities, the complexity of care for older adults who receive care in various settings, and then what we know about the disproportionate harm that older adults face within our healthcare system as related to the care that they receive. So if you go to the next slide. So from that, the mission of age-friendly health systems was to build a movement so that all care with older adults can be considered age-friendly care. And what that means is that it's guided by an essential set of evidence-based practices of the 4 M's, and I'll talk a little bit about each one of those M's in just a moment, that it causes no harm and that it is consistent with what matters to the older adult and their family. So if you go to the next slide. To take a step back in terms of where the 4 M's and the framework came from, Terry Fulmer, from the president of the John A. Hartford Foundation, tasked IHI to be able to support work that they saw as important around age-friendly health systems as the funder of the work. And so they brought together IHI and the John A. Hartford Foundation in the early days of this work, a number of experts in the various fields of older adult care to look through the existing care models that existed and look through the evidence and really come up with the vital few areas of care that, if assessed and acted on reliably within a care setting, would lead to better outcomes and experiences for those that we care for. So if you go to the next slide. And for that vital few, what the expert panel came up with was the 4 M's. And so what the 4 M's are is what matters, or knowing and aligning care with each older adult's specific health outcome goals and care preferences. And the last sentence here is actually really important. It's not limited to just end-of-life care and end-of-life decision-making. It's actually about what matters to the older adult in terms of what they'd like to be able to do as part of their life and what they'd like their care and their health to be able to help them to achieve. And it's asking that question across a number of settings, from acute, outpatient, primary care, nursing home, and work that's even happening now in convenient care clinics as well. When looking at medication, it's thinking about when medication is necessary, using age-friendly medications that do not interfere with what matters to the older adult, their mobility or their mentation across settings of care. For mentation, it's preventing, identifying, treating, and managing dementia, depression, and delirium across settings of care. And of course, within the different settings, the specific aspects of what's being assessed for and treated is a little bit different. And I'll talk a little bit about some of the customization that happens across the 4 settings of care now. In just a moment. And then for mobility, ensuring that older adults move safely every day in order to maintain function and to do what matters. So of course, each of those M's is important in and unto themselves, but it's really what we talk about most is the 4 M's as a set, and ensuring that the 4 M's are assessed and acted on reliably as a set for all older adults that we care for. That is really the goal of the age-friendly health systems, and being recognized as an age-friendly health systems participant and committed to care excellence. So if you go to the next slide. Why the 4 M's? Well, really, it represents the core health issues for older adults and builds on a strong evidence base, as I just mentioned. And one of the things that really was the goal of coming up with the framework, but also has been reflected back by those who have applied it within their setting, is to be able to simplify the different models of care that currently exist and the evidence that exists around the core components of care for older adults, to make it easier for systems to be able to look at assessing where they are and what's already in place, and how they might be currently assessing and acting on each one of these M's, and look at what opportunities there is to bring care together and ensure that it's more reliable, and that it's synergistic and reinforces one another. You know, what's interesting to me is that recently within my own family, I had the opportunity to reflect on, from a loved one's experience around constant falls, how those 4 M's may or may not be in place for someone that I care about. And it was, interesting to me, because thinking about the incident of reoccurring falls, we were able to go through each one of the M's and think about, well, what are the medication that this person's taking that might be impacting their mobility and their mentation? If there's concerns about cognition, what's happening around, has there been a current assessment? Is there something that we might be able to do to support optimal cognition for this individual? What matters to this person that's very important to me? And how can we ensure that all of the care and supports are in place to enable this person to be able to do what matters to them on a daily basis? And so you really start to see that it's really the 4 M's as a set and how they are in play and being supporting what matters for each individual. That is the vision and the goal, and what really makes the most difference. So if you go to the next slide. There is a summary of the evidence that supports each one of the M's, and oftentimes we're asked about sort of the impact of the 4 M's framework, and one of the things that we can rely back on is that because, of course, the 4 M's came from a review of the evidence, we know that there is robust evidence for each one of those M's, and it is summarized here within the paper that you see, and the links that I believe that you can get access to in the chat. Additionally, I just learned today, actually, that there's over 300 references to the 4 M's framework or age-friendly health systems in published and peer-reviewed literature now. So we're finding that age-friendly health systems and the 4 M's is showing up more and more within the literature that exists, really indicating that it's something that's making a difference for folks in terms of how they're thinking about and focusing on the care for older adults within their setting. Now, if you go to the next slide, what all of you will most want to hear about is, so what does this look like for nursing homes or for long-term care facilities? So just one piece of background, of course, being an improvement organization and an improvement advisor myself, we're always thinking about what are some of the primary drivers or the key buckets of work that we can focus on as it relates to be able to achieve the goal we have around reliable 4 M's care. So for each setting of care, we have a driver diagram, a theory of change around the key things that we believe systems need to focus on in order to provide reliable 4 M's care to the older adults in that setting. And for every single one of the settings, the 2 primary drivers, which you see on the screen here as those 2 sort of offshoot boxes, they are always assessing the 4 M's and then acting on the 4 M's and incorporating them to the care plan. So for every one of those settings of care, those are the 2 components that we think about, and then the specific key actions associated with assessing each one of the 4 M's and acting on each one of the 4 M's is customized to that care environment. So if you think about the 4 M's in the next slide, for skilled nursing facilities and long-term care, the key actions that are important within that context is asking the older adults around what matters, documenting what matters, and ensuring that all team members have access to it. And that's oftentimes one of the key considerations for systems that we're working about. Is not that we're not having these conversations, but it might be that the information that's gathered from these conversations is not available to all the people that are interacting with that individual as part of their care. Reviewing medications and looking at being able to address any high-risk medications, screening for delirium, as well as screening for dementia and depression, and then screening for mobility. So that is sort of the assess key actions when it comes to the long-term care nursing home environment. In terms of act on, to flow from what's found from those assessments, aligning the care plan to what matters, deprescribing when necessary, thinking about hydration, orientation, ensuring that older adults have their adaptive equipment, that sleep is not interrupted, managing behaviors and supporting folks to live well with dementia, and then thinking about factors that are contributing to depression and promoting safe mobility. So one of the things that's probably really important to note, a lot of you might be reading through this list and saying, yes, absolutely. These are things that we already do within our facility, that we're focused on within our care already. And that is across the board what we hear. Nobody who comes into the age-friendly health system movement and starts thinking about the 4 M's is starting from zero. There are always components of this care that are in place, but they may not be reliable, or they may not be integrated with each other in the way that they could be to provide the best possible care for all older adults that you care for. So that, in a moment when I talk about the steps to becoming age-friendly, understanding where we start and seeing this as a framework that is not intended to duplicate or be in addition to, but really complement and bring together what might already exist and identify areas for improvement, is something that hopefully all systems that look at this would be able to say, yes, 75% of this is something that we already do, but maybe having those what matters conversations and making sure that that information is available to all members of the care team and of staff who support the older adults in our facility is something that we can focus on to really look at all 4 of those M's as a set for those that we care for. You go to the next slide. We have found, so I said in the beginning that the aim of age-friendly health systems was to get to over 2,600 by the end of 2023. We have blown through that goal, and we now have over 3,000 settings of care that have been recognized as a participant within the movement. And I actually just saw an updated slide on this today, and it was 3033. So we've had 12 more since I had these together on March 6th that have been recognized as participants. And what that means to be recognized as a participant is that they've taken the 4 M's framework and they have documented what assessing and acting on each one of the 4 M's will mean for them within their setting of care. And as part of the resources that we'll link you to at the end of the presentation, every system to be recognized as participant has to go through sort of documenting this is what the 4 M's means to us based on the assessments we already use and some of the actions we already do, or maybe we're going to focus on. They submit that to IHI, that's reviewed to ensure that aligns with the evidence, and then you're recognized as a participant and you're provided with some materials around that. From that group of over 3,000, there's been 931, and I believe now it's 935, that have been recognized as committed to care excellence. And that means that they've taken that 4 M's care description and they've actually started looking at reliably being able to provide care to the older adults within their setting, and then count the number of older adults who receive that care and submit that for at least 3 months to be recognized as committed to care excellence. From those numbers, so these are for all settings of care, around 15% of that 3,000 are actually nursing homes, and around 30% of the 900 are nursing homes. So we actually see a larger conversion rate of those who are recognized as participant to be recognized as committed to care excellence within those 2 stages. The ability to be recognized as an age-friendly health system participant or committed to care excellence is free. It is open to anybody internationally. We have folks that are recognized in Qatar, in South Korea, in Ireland, in Australia, and in other countries around the world. So if that's something that folks are interested in, it is definitely available to you. So go to the next slide. When we are working with systems in our action community or beyond, one of the things we're talking about are what are the steps of becoming recognized as an age-friendly health system? And these are them. And so, as I said just a moment ago, the first step that we support systems through is really understanding the current state, because as I said, we know that no system is coming in without there being at least some aspects of the 4Ms in place in some of the time. And so being able to start off with a recognition of where we are, where is this already happening that we can capitalize on is important. From that, figuring out what the 4Ms will mean for your system of care, depending on the setting in which that care is provided in, and describing that. And then from that description, understanding, what are the tools we're going to use to assess? What are some of the key actions that we're going to use to act on those assessments? What might be the adaptations that we can make to our workflows so that that care is able to be provided consistently, providing that care, studying our performance, and then improving or sustaining care consistent with the 4Ms. Now, if you go to the next slide, of course, this being IHI being an improvement-based organization, the model for improvement and the concepts around quality improvement underlie all of this work. So one of the things that, for those of you that are savvy improvers yourself, and I know that we have a number of you on the phone, hopefully what you will have noticed is that those 6 steps themselves lend themselves well to the improvement process in general. So as part of those early steps, we're actually asking systems to make an aim, and in some of the materials that you'll have available to you, it'll ask you to set an aim for your setting around the number or percentage of older adults that you would like to be able to provide the 4Ms care to within a certain time frame. Within steps 1, 2, and 3, you're inherently identifying areas of opportunity and specific changes that you would like to make based on how the 4Ms has been described for your setting. In step 5, of course, and I'll share with you in a few moments some of the recommended measures that exist for systems. And then the use of plan, do, study, act cycles, or small tests of change, are how we encourage systems to take an area of opportunity, such as, thinking about what matters conversations, or if you're already collecting all about me information as part of the interactions with those within your facility, how are we able to make this information available to more people? How are we able to take what we know about what matters to an older adult and integrate it into various activities that are planned within the facility? So using PDSA cycles to test different ways in which we are looking at each one of those M's and making them more reliable, or being able to view the 4Ms as a set for more older adults within our facility, is the way in which we think about testing out new ideas and then making them more sustainable and reliable within our systems. So if you go to the next slide. What's probably most meaningful for all of you is actually getting a sense of, okay, so what does this actually look like? Tell me an example of what does the 4Ms look like within a nursing home long-term care environment. So this comes from a video that was sort of a case that was shared with us in our action community last year. So last year, we started each action community in March of every year, and it ends in October. So the Cedars, which is a nursing home in Portland, Maine, joined us in March of 2022, and they gave us this example of what the 4Ms and the age-friendly health system journey had been for them as part of our celebration in October. And what Angela Hunt shared with us was that when they came into the action community, their use of antipsychotics had really crept up during COVID. And I think that they are probably not alone in this. There might be others on the phone who recognize that this is a struggle they've had as well. And so they were at about 28%. When they joined the action community last year. And so they saw the exploration of the 4Ms and the 4Ms framework as a way to focus on how some of the strategies that might exist around reducing the use of antipsychotics within their facility, which really gets at that medication M, of course, right? And how they did that was actually by thinking about the use of the What Matters M and capitalizing on some work that they already had sort of earmarked around their All About Me process and collecting that information, as well as training and resources from Teepa Snow's work around care for those living with dementia, and ensuring that all staff within their facility, including cleaners and those who are working in the dietary department, not just those who are providing direct care, are trained in some of the strategies, resources, and ways to be able to support those living with dementia. And so through the 4M's work, they identified some of these opportunities around the ability to deprescribe medications, antipsychotics, the ability to think about making the access to that information they had about what matters to individuals more available, and some of the ways in which they were acting on, a positive knowledge around someone living with dementia. How are they acting on to support that individual within their care, to bring those together within the work that they were doing. And what they found through the various ways in which they move forward in some of these different initiatives was that they went from a rate of 28% to a rate of 8% as they came through the action community, and which put them sort of below the average for their region in use of antipsychotics. So the 4M's itself was something that was not sort of a replacement for what they were doing. It was really helping them to see how a number of things maybe that they already had planned would be able to come together and be seen as a set and reinforcing within this framework, as well as thinking about how might we be able to make some of what's happening more reliable within our setting. What they are now doing, because they initially tested this within one neighborhood within their facility, they also provide rehab services within that facility. And so now they're thinking about, based on the success they had with their nursing home residents, how can they use some of these same processes and looking at the 4M's for those who are there for rehab. And so that's what we often find, is that systems who are doing this work with us, they're starting within a pilot site. They're testing out the assess and act on for each one of the 4M's in their pilot site. And then they're looking at how might this be able to be used in other parts of this facility. So we're starting in, let's say, one neighborhood. How might we be able to use this in other neighborhoods? Or if we have a multiple facility or long-term care homes within our system, we start in one home, and how might this be something that's useful to other homes as well? So if you go to the next slide. On the next two slides, I just have a couple of quotes. When folks submit information as part of the Becoming Committed to Care Excellence, we ask them for some reflections on what this has meant to them. And what we often hear are quotes like this, which really reflect back on, as part of the 4M's work, that asking of what matters, and the ability to make asking and acting on what matters more reliable in care to be something that is the most meaningful for those who are involved in this work. And if you go, you can go to the next slide as well. And that's one of the reasons why the what matters aspect of the 4M's is often referred to as the North Star, because it is something that is sometimes new for those facilities that we're working with. And it really underlies the act on components for all of the other M's within the framework. It is something that is sort of top of mind for all the other decisions that we make as we move forward. So if you go to the next slide. As I said earlier, there are a set of measures that are recommended for those who strive to become age-friendly. This is, I hope one of the things that's come across in my comments to date has been that the idea behind the framework is that it's flexible and you're able to customize it to what might already be in place or the opportunities in your setting. The measurement framework is no different from that. So we've created a measurement framework that is intended to be generalizable and sort of picks up on the need to measure key processes around how reliable are your assessments and some of the key outcomes that may be related to the care that you're provided, with the ability for each setting, each organization who's involved in this work to customize those measures to what you already collect, or what are some of the key outcomes that you're able to get access to within your data systems. Again, the idea which underlies measurement for all improvement purposes, that this is measurement that should be enable you to know whether or not what we're doing is reliable and working and having the impacts we hope it will have, but not be something that is so burdensome that it takes away from our ability to actually do the work. So there are resources that guide some of those conversations, and then systems themselves that we work with really specify what those measures are going to be for them, and ideally collected on a monthly basis and stratified by age, race, and ethnicity, so that we're able to ensure that all older adults are receiving equitable access to the 4M's. To that end, if you go to the next slide, This conversation around equity and what does equity mean within the age-friendly health systems has been one that I've had the great pleasure to be a part of over the last year and a bit. We actually worked closely with 5 systems in 2022 to learn more specifically around what does it actually mean to be equitably assessing and acting on the 4 M's within a setting. So if you go to the next slide, and what we found was that similar to how you have the recipe of the 4 M's and the 6 steps to becoming an age-friendly health system, there are ways in which we can think about bringing in the lens of equity to each one of those steps, which starts with understanding what's currently happening within our health system around diversity, equity, and inclusion, how age is represented within that, and how we might be able to ensure that our age-friendly health systems work is really reflective of work that is already underway or needs to be underway around equity within our system. I'll let you read the specifics that are on the slide yourself. There's also a paper that has been written that you can refer to. What I think I'll do is sort of provide you with some of the examples that came up in the systems that we were working with. So one example that came through for a number of systems was around the importance of assessing for the social determinants of health and ensuring that as we're looking at the assessments for each one of the 4 M's, that we actually understand how, if there are recommendations around act on for 1M, do we understand whether or not the older adults we care for have all the resources that they need to be able to support their mobility, let's say, within their setting. And so being able to, for instance, in one hospital we were talking to last month, they know that a large number of their older adults in their care struggle with food security. And so are we assessing for food security and food insecurity? Are we connecting people with resources in the community so that they have the nutrition that they need, so that they can do the things that are most important to them alongside the recommendations that might exist around mobility or the other M's. Additionally, another example that came up with some of the work that we're doing internationally is thinking about when we're having conversations. I mean, what matters conversations, they're not exclusive of, they're not just end of life conversations, but they do involve a component of that. Do we understand some of the different ways in which end of life is approached in the cultures of those that we care for? And can we ensure that those conversations that we're having are respectful and reflective of the way in which different cultures see the experience of end of life? And can we ensure that we have resources and supports in place to make that honor and respect the different ways in which the families that we care for would like to be able to move through that phase of our journey? So that we are still learning about how equity shows up within the age-friendly health systems work. And we hope to be able to provide more examples and ensure that it's part of the conversations for systems as they move through the age-friendly health systems movement. If you go to the next slide. That's the paper that I referenced. So I think that'll be, you have access to that to read at your leisure. And I'm coming to the end of the last few slides here. So I want to make sure we have time for discussion for those who would like to ask questions. If you go to the next slide, one of the questions that comes up, because we've had over 3,000 systems that have been recognized as participant, the question becomes, why is this something that has spread? And why are there, different countries that are now looking at how the 4 M's can be applied and adapted within their setting? I think the first and the thing that's really most important is that it builds on existing initiatives and processes. It's not meant to duplicate. And so it's helping to be able to bring together what might already exist and identify areas that you want to work on. And in that way, it also simplifies focus. So when we were having a conversation around the equity components within age-friendly health systems, some of the systems we were talking about was saying one of the most important things is that you're able to bring through that thread of ensuring that we're able to reflect the beauty around the simplicity and what are some of the key things that people can think about as they move through this journey. And so that focus on the simplicity of the 4 M's, which really helps everyone within a caring environment to better understand the key components that we need to assess and act on, has been really appealing and has made it easy for folks to be able to take it up and test and implement it within their setting. Just like being part of LTC Plus and being part of a hub and being able to speak to other long-term care facilities doing the work that you're doing, the ability to connect in with action communities and some of the different ways in which we connect systems across this work has also been a valuable resource. There are now, I think, there've been over 15 action communities that have brought systems together who are looking at this work, and there's different ways in which we network people in some of the online venues as well. And it's free to join. So anyone, including any of you who are interested, can join. It's all underwritten by the John A. Hartford Foundation, the resources, the action communities, and the recognition process, which really reduces that barrier to entry. And then, of course, the focus on what matters, as I mentioned already, is something that has been seen as very valuable and meaningful, and I think draws a lot of people to this work right from the onset. Next slide. In terms of some of the nuts and bolts around resources, in the last year, in 2022, they released some specific guides around the 4 M's in the nursing home environment. So there's a workbook that leads you through some of the different steps in becoming an age-friendly health systems journey and how that applies within a nursing home environment. Again, free of charge on the IJ website. And then the guide, which we have for inpatient and outpatient settings, has also been customized for the nursing home setting. Go to the next slide. And then there are a number of ways in which people are able to engage. So action communities, as I said, are open to anyone. Our action community for 2023 actually launches the Getting Started webinar tomorrow, but you're able to join if you would like to at any time. They're monthly webinars with optional peer-to-peer learning conversations as well. And then there's also a DIY pathway. You don't have to belong to an action community. You can just do it on your own. And we do have a number of systems that have done that. You can still submit and become recognized as part of that DIY pathway as well. And on the next slide, there's also now an open school course that is free for those of you that have been part of the open school before or who haven't. It's sort of like, it's a self-paced online learning module that allows you to explore age-friendly health systems in the 4 M's. And that's something that's available to folks as well who would like to use that as a resource for learning and testing within their own environment. And on the next slide, I think that is the link for the website where more of this information is held. And you can also find, we have a growing number of case studies that represent the 4 M's in place in all the settings of care, including the long-term care and nursing home environment. And so you can access more information examples there. Yeah, so I think, Neil, I can stop there and invite any questions from folks around the 4 M's and the age-friendly health systems movement and what they'd like to know more about.
Thanks so much, Christina, for the presentation, and also for just walking us through the 4 M's framework. I mean, from what you shared, it sounds like it's a relatively simple and no-brainer type of framework because a lot of it, as you mentioned, are things that many facilities are already doing, but bringing it together. So I do invite all of you, if you have questions. I know we've received a few, but continue to pop them in as you think of them, and I can start. And maybe this is something I'm sure you've thought about, but why is there only 4 M's? Like what about things like, for example, multi-morbidity or malnutrition? Like, what was the rationale behind that? If you could speak to that.
Sure. So when the experts that came forward with the 4 M's framework, they were really tasked with what is the vital few. So because this is a framework that's intended to span across a number of different settings of care, is thinking about what are the vital few things that if was assessed and acted on reliably for all older adults across different settings would lead to better care and outcomes for those we serve. And so they came up with the 4 M's as being those vital few. If these 4 things were done all of the time, it would make a difference. That's not to say that systems, because it's a customizable framework, can't add a 5th M if they would like to. So malnutrition is one that has been added as a 5th M in a number of settings. When I was talking about the example in the equity framework components around assessing for food insecurity and connecting folks with nutritional supports, that system that's doing that work has actually added malnutrition as a 5th M, so that because they know that it is an acute issue within the community that they serve, they have added the focus on reliably assessing nutrition. and then acting on connecting people to resources where needed. So we do have systems that add a fifth M. We ask for the 4 to be reliable, and then you can customize it to add the fifth. And I would say malnutrition is the most common fifth M that people add, but there might be others that folks within that are looking at the framework would like to add, and they can do so as long as they have the basic 4 in place reliably.
Great, thank you. So yeah, now maybe we'll go to some of the questions we received from our audience. So I think you had mentioned organizations who join can be recognized as committed to care excellence. So what does that look like for an organization? Is it a certificate, a pin? What do organizations get?
So in order to be recognized as committed to care excellent, there's sort of 2 steps. So first, you have to be recognized as a participant, which means you have to have taken that 4M's care description for your setting. So if it's nursing home long-term care, there is a specific 4M's care description for nursing homes long-term care, which is linked on the website. You have to fill that out, which asks you to document what are the assessments for each M and how are you going to act on each M within your setting. And then once that is approved, you're able to then start counting the number of older adults who are receiving your specific description of the 4Ms. And once you submit 3 months of counts of the number of older adults who receive all 4Ms as a set, you can be recognized as committed to care excellence. Once you are recognized as committed to care excellence, there's like a press kit that you receive. And it's like that little logo that you saw on that slide. You get access to that. You can add that to your own promotional materials and use it in a way that would make sense for you. So that's sort of that's what you get as part of that recognition, as well as, I mean, you get an email that says that you've been recognized in that way. So there is some sort of press communication information that's used. And then there's a website I didn't include in the slides, but there's actually a listing of all recognized sites across the world, I believe. And so you'd be added to that list as well. That's on the HI website.
Okay, great. So some good promotional opportunities if you participate. Another question we received, in the context of the 4Ms, what is the difference when you talked about equity versus equality?
Oh, that's a very good question. Okay. So when we think about equity, we think about ensuring that all older adults are able to receive the 4Ms reliably. And I think thinking about sort of the classic way in which we think about equity versus equality, it's not that everyone gets the same, but that everyone gets what they need to be able to do what matters most to them. And so, when I think about the way in which we frame conversations around equity, one of the things that we talk to when we're talking about it with systems is actually, how can we think about starting with older adults who are with marginalized older adults in our system? When we're thinking about asking what matters, can we actually start with those older adults and ensure that they are centered as part of our focus on asking what matters and understanding what's most important to them, because their voices are less often heard. So it's definitely not a question of everyone getting the same. It's a question of understanding what might need to be some of the customization and the nuances around how we hold conversations, some of the resources that are available. Another example that came from one of our systems was thinking about the different types of caring relationships that exist within our community. And do all of our materials reflect the caring relationships that exist for diverse sexual orientation and gender identities? A fantastic resource came out last June out of the city of Toronto, actually, around for nursing homes, around LGBTQ+, and how do we make those environments welcoming and accepting? And so as part of the movement, we think about what are the customizations that need to be made within your system so that all older adults reflective of the demographics that you care for feel respected, are receiving the care at the same to the same extent. There's no disparity within who's being assessed and who's receiving those resources, and that they are getting what they need to be able to do what matters to them. I hope I answered that question in the way that person was hoping.
I know that makes sense to me, Christina. So thank you so much for that. Another question we got is, are there examples of age-friendly health system organizations that have made this work for clients with complex needs, who are, I think I'm understanding it, there's numerous providers obviously involved in caring for those individuals who have complex needs. So can you share any examples about how that's worked for the 4M has worked for folks who are maybe a bit more have more complex needs, and care? We know that care isn't usually provided by a single provider or practitioner. So how does it work when there's so many different people involved in care?
So there's two things that I'm thinking about with that question. The first thing I'm thinking about is, so we have with 3,000 plus settings that have been recognized as committed to care excellence, there's a growing diversity in the types of care that's being provided. So we have focus work that's now happening within cancer care. There is, of course, a large representation of those who provide specialty geriatric care settings, and then a growing number of sort of like nursing homes and those who provide care to more complex older adults. So yes, there are examples of systems that provide care for those who have who require or have more complex care needs. And again, it's looking at what are the ways in which the assessment for each one of those 4Ms is sort of brought together and shared within the care team, so that the decisions that are being made are able to align with what matters to that individual and their family. And really support those goals. The other thing that actually we know less about that I think would be equally important within that context, and maybe there are some on the phone that would, or on the webinar that would be able to help us with that, is actually about how the 4Ms are used within transitions. So we have systems that are looking at, which of course with complex care, the multiple transitions that happen between the care that's happening across settings, is something we know less about how we can do that well. So we have systems that are involved to provide care across the journey of care, from sort of outpatient services all the way through to nursing home long-term care. But even those systems that have looked at this across the multiple settings are still figuring out, how do we ensure that this information follows somebody and that it is consistent across all the different care environments and the specialists that might be involved, and the inpatient stays that might be involved, or if someone is a resident of a nursing home. And so I'm hopeful that as we also get more sophistication in some of the electronic systems that support that, that we'll learn more about that journey. But that 4Ms on at transitions is actually something that we need to know more about. How do systems do that well? Because we know that there can be a gap, and folks can have that information fall through the cracks as they move between those different settings of care.
No, absolutely. And I think that's one of the challenges, of course, not just for the 4Ms, but for integrated care across all different settings. So definitely look forward to anybody who can provide examples around that. My slides just moved a second, but one of the it was a comment, but I think it aligns with some questions I had, was that there was an acknowledgement from somebody that this person finds that residents and families have a hard time articulating perhaps what matters. So I guess how can, from your experience and what you've seen, how has this been addressed in some of the facilities, and how do you measure it? How do you articulate it, or how do you support people to tell you what matters, and how is that measured? Can you speak to that?
Yeah, that's a fantastic question, and one that actually many systems grapple with. So I'll take the first part of that question, which is, how are we asking residents, patients, and their families about what matters? That is actually something that systems are often doing a lot of testing around in the beginning. So in Hub 8, I know I have a number of our facilities that are part of our peers in that group who are looking at that all about me process, right? How are we collecting information about the resident and their families? So one of the things, like in the Cedars, what they did is they actually took that process that they had that existed as part of admission, included questions that reflected each one of the 4Ms as part of that process to be able to gather what matters information that they were able to then use to align with care decisions around sort of activities and some of the different supports that would be in place. So I think within the nursing home environment, I actually think there's potentially a better opportunity, because this is already an aspect of this is already something that is part of the processes around collecting information about each resident. It would be looking at how are we asking questions that get at what matters to that resident as an individual, as a person, and how are we using that information to share it with all the members of the care team that can use it to guide the way in which we are supporting this individual in their everyday interactions and in some of the different care decisions that are made. Within the other environments of care, such as like acute care and primary care, how they ask what matters questions that get at the type of responses that are helpful for care decisions in that environment is a little bit different because it's not their home. Right, within the long-term care facility, this is their home. They're spending all of their time with you. So the types of things that you might be asking and looking for will be a little bit different than within the acute care or the primary care outpatient environment. And so there's a lot of testing that happens around how can systems ask that question. And there are examples. There's actually a What Matters guide on the website, which lists a whole bunch of different types of questions that systems have tried and ways in which they set up the conversations so that they're able to get the information that is most useful for guiding care decisions. And I would also say there's also a growing focus on the role of the caregiver in those conversations to be able to help in bringing forward information. There's also Donna Fick, who is one of our faculty around mentation, is also very clear that even in those living with dementia, there are ways that we can have conversations around what matters to them, and there are ways that we can understand the signals that are happening, that are present in behavior and in communication, to still have elements of what matters conversations with that individual, even though they might look a little bit different. I'm not an expert in that domain, but I know as part of the resources and so the conversations we have in the action community, Donna will talk about, how do we have what matters conversations with someone that's living with dementia so that we can still understand to the best of their abilities what matters to them and how we can use that information to guide care decisions. So it's not a one size fits all answer. It's something that systems have to test around and really look at what exists in their current processes that you can leverage and maybe adapt a little bit so you get the information that's useful for you in guiding some of those act on components.
Great. And just if you can add anything about the measurement.
Yes, the measurement.
Yeah.
Yes. How could I forget, Neil? My goodness. So the process aspect of it is easier. Is there a documentation in every patient's record around having a what matters conversation is usually the measure that we have around processes. That is like, I can get into the nuts and bolts around folks how to do that. If they have Epic or something, they're looking for like a tick. Did you have a what matters conversation? Has the all about me form been pulled out? Or there's sometimes folks are using drop-down menus to sort of look at most common responses. That's more acute care examples. But usually that's sort of for the process. Did we do it? It's like, has it been documented in the care record? It's more complex when we start having conversations around outcomes. Were we actually able to act on that information in the best possible way? And so that's where oftentimes what we're talking about is how might our ability to successfully act on what matters to an older adult, how might that be impacting other outcomes that we are tracking, right? So like in the Cedars example, they were, their use of antipsychotics, I think they saw that as being something that was multidimensional, and that by working in some of the stuff that they were doing around their All About Me forums, looking at some of the things they were doing around supporting those living with dementia, all of that was coming into their ability to decrease their antipsychotic use. So it was sort of like, they knew that if they were successful in some of those what matters conversations, it would have a positive impact on their antipsychotic use. And I think that's that's sometimes what systems are more often doing, is sort of thinking about what are some of those pathways that we see between being able to provide more patient-centered care, and what are the impact of the outcomes. We do have a recommendation around a tool. It's called Collaborate, which is a way to be able to assess care decision making and whether or not a patient and their family member feels that their care is representative of what matters to them. And so that's one thing that we have had some folks explore. It's a survey tool. So if there is if there's a survey that's happening within a facility, that would be another way to be able to look at outcomes. But it's definitely a less clean measure, and would probably be a bit of a combination of things, because the act on portion of what matters is so intertwined to some of the other M's as well.
No, it's that makes sense. And I know I wasn't expecting a simple answer, because I know it can be a bit complex, but I think the way you articulated that makes sense, especially with the reduction of antipsychotic use. So the last, I know we're getting close to time here, but I think the last, it's maybe more of a comment and maybe a plug, because we've heard a few questions. I'm interested in hearing from long-term care reps on the call who are already using the 4Ms at their site. And the second related comment is, I'm not seeing a lot of Canadian sites recognized. Is this accurate? So is this an opportunity for folks on the call?
Yeah, no, I don't think we have any Canadian sites that are actually recognized. And if they are, they don't tell me about them, which is shocking, because I'm Canadian, so I expect them to let me know. I think it's an excellent opportunity. And so the short answer is no, there have not been any, I think, Canadian sites that have formally recognized. Yes, absolutely. Canadian sites are welcome to be a part of it, to join the action community, to do the DIY process. It's all free. As I said, there are sites nationally that, thank you. I see someone said challenge accepted. And I'm happy to sort of answer any questions that folks might have about that process, because it is something that there are resources that are available. So did I answer that question, Neil?
I think you did. And I was
okay.
hoping that you would point to the opportunity that I think there is, and we're already seeing a few comments on the chat box. So if you are informally already participating, then feel free to chat in your experience. But if not, I think Christina indicated that she's welcoming follow-up questions about how to sign up or learn more after this call, and we can make those connections.
Yeah, maybe Neil, sorry to interrupt. I'll just make a plug. So the action community does start tomorrow. That's our getting started webinar, but you can join after. I don't expect everyone to be able to join at 3 p.m. tomorrow for the webinar. And that is similar to the experience of a hub, where it's a larger group, so it's not as personalized as experience in a hub, but there's a monthly webinar that you can join, as well as a virtual convening where we do a little bit of a deeper dive, and then some peer discussions for just those who are nursing homes, long-term care homes. So if anyone would like to engage in that way, you can go to the website, sign up, it's free, and you'll receive those information. You can also, everything is available offline after the fact, so you can review them at a later date, if that makes sense. So that's an upcoming opportunity for those who are interested, that provides you with a little more support as you go through the process.
Okay, super. And so if you're not able to join tomorrow, you'll still be able to access some of those resources and materials. Thank you so much, Christina. The IHI website, yes, it's and that was the question. The information is on the IHI website. Yes. So thank you to the audience. Super engaging and excellent and very timely, relevant discussion, hopefully. And again, thank you to Christina for really shedding light to our Canadian audience on the 4Ms framework. So last thing, we really appreciate, as you know, any feedback about this session and checking in to see if it was helpful to you. So we're just you'll see a poll right now popping up on your screen. Invite you to answer those questions. And just a note, the question on gender is optional, of course, and it's collected on behalf of our funder, Health Canada. So I just want to point out that our next webinar will be April 18th. from 1 to 2 p.m. Eastern time, and we'll be focusing on research related to staffing models in long-term care. We look forward to seeing you all there. And once again, thank you to everyone and Christina for the excellent webinar today. Have a great day.